Imagine walking into an operating room and seeing a patient's abdominal tissue physically suspended from the ceiling by heavy orthopedic meat hooks.
Yeah, it really does look like something out of a medieval torture chamber, doesn't it?
It really does.
Mm,
But, it is actually a life-saving, highly calculated surgical maneuver.
okay.
Welcome to the deep dive on body contouring and abdominoplasty.
Exactly. And if you are listening to this, you are likely staring down the barrel of your board exam. So our goal today is to give you what you need.
Right. Our mission is to rapidly extract the most critical, high-yield facts for your FRCS revision. We are skipping the generic summaries and getting straight into the physiological mechanisms and anatomical traps that dictate survival versus necrosis on the operating table.
Sounds like a solid plan.
But before we get into the anatomy, you need to head to medsynclimited.com and get the FRCS Plastic Surgery Anki Deck with over 6,000 questions arranged by topic to help recall key facts based on the textbook Keynotes in Plastic Surgery.
All right, so that imagery of the ceiling hooks is actually a perfect place to start because it highlights the sheer mechanical force we are dealing with in body contouring.
Oh, absolutely.
I mean, before a surgeon even considers making an incision, you have to master the underlying connective tissue architecture that handles all that physical stress.
Right, because we aren't just stretching skin here. I always try to map this to facial anatomy just to make it stick. Like in facial rejuvenation, the SMAS is the vital structural scaffolding we suspend to avoid putting tension on the delicate skin edges.
That is a great analogy.
So is it accurate to think of Lockwood's superficial fascial system, the SFS, as the exact equivalent tension-bearing network for the trunk?
That is a brilliant way to conceptualize it. The SFS isn't just, some arbitrary layer of fat. It is a highly complex, three-dimensional connective tissue network.
Like a structural web.
Exactly. Imagine it as a series of horizontal membranous sheets running through the subcutaneous fat, but critically, these sheets are tied together by interconnecting vertical and oblique septa. And this network extends all the way from the subdermal plane deep down to the muscle fascia. It acts as the primary biological support system, anchoring the skin down to the deeper, rigid tissues.
So if we just rely on the dermis to hold an abdominal closure together, we are basically asking a relatively weak structure to bear the entire mechanical load of the trunk.
Yes, and it will fail. If you close just the skin under tension, the dermis suffers from localized ischemia.
Right, the blood supply just gets choked off.
Exactly. The wound breaks down, or at best you end up with these wide, hypertrophic scars. But when you specifically identify and suture the SFS during your closure, you are acting as a biological shock absorber.
Which diffuses the tension.
Right. You diffuse the immense closure tension away from the fragile skin flaps and transfer it to this robust fascial network.
That structural logic really makes it easy to understand why the zones of adherence are so critical, because the SFS isn't uniformly loose everywhere, right?
No, definitely not.
It tethers the skin at very specific anatomical landmarks to define our body contour. We have the inframammary creases, the groin, the gluteal folds, and the periarticular creases around the joints, plus those vertical anchors at the anterior and posterior sagittal midlines.
Precisely. And in a massive weight loss patient, that entire skin, fat, and SFS unit has been stretched completely beyond its elastic limit.
Yeah.
The structural integrity of those zones of adherence is just completely destroyed.
Which brings us right to the origin of that destruction. I mean, the patient's bariatric history.
Uh-huh.
We know bariatric surgery is the most consistent long-term solution for patients with a BMI over 40.
Absolutely.
But from a reconstructive standpoint, the physiological fallout from these procedures is vastly different depending on the specific plumbing alteration the general surgeons perform.
Right, the anatomy changes everything.
Let's look at the purely restrictive procedures first. Like the vertical banded gastroplasty or the adjustable gastric band. They just create a smaller proximal stomach pouch for early satiety. What is the surgical trap here for us as reconstructive surgeons?
Well, the hidden danger with the adjustable band lies in its mechanism. It uses a circumferential silicone balloon around the upper stomach, which is controlled by a subcutaneous inflation port.
Oh, right.
And that port is usually buried right in the abdominal wall. So if you don't palpate and map exactly where that port is preoperatively,
You're going to hit it.
exactly, you will blindly slice right through the tubing during your subscarpa's undermining. You'll leak saline everywhere and essentially destroy the bariatric device.
And there's a massive anesthesia risk too, isn't there?
Yeah.
Because if a patient comes into the OR with that band fully inflated, they're lying flat on their back for a 5-hour abdominoplasty with a functional obstruction in their upper digestive tract.
Yeah, it is a recipe for a catastrophic aspiration event upon extubation. Those bands absolutely must be actively deflated prior to any body contouring surgery to eliminate that risk.
Wow, okay. So that covers the mechanical traps of restrictive surgery. But what happens when we introduce malabsorptive procedures, where they combine restriction with intestinal bypass?
That's a whole different ballgame.
Right, I'm thinking of the biliopancreatic diversion, the BPD, or the duodenal switch, which I know specifically preserves the pylorus to improve gastric emptying and prevent dumping syndrome, and of course the gold standard, the Roux-en-Y gastric bypass.
So when you bypass the absorptive surfaces of the duodenum and proximal jejunum, you aren't just limiting calories, you are fundamentally altering the patient's ability to absorb crucial micronutrients.
Because they just aren't hitting the right parts of the gut anymore.
Exactly. These patients are malnourished by design. You have to actively hunt for specific deficiencies because if you operate on a depleted patient, their cellular wound healing machinery will essentially just stall out.
Let's break down the biology of those deficiencies. Examiners are definitely going to test this. We are looking for the 3 key B vitamins, right? B1, B9, and B12. So thiamine, folate, and cobalamin.
Yes, and think about what those actually do. A B12 and folate deficiency directly impairs red blood cell production.
Right.
If your patient is profoundly anemic, they cannot deliver adequate oxygen to the distal edges of a massively undermined abdominal flap. Hypoxia leads straight to marginal necrosis.
It's a disaster.
Totally.
Yeah.
You also have to check iron levels for the exact same oxygen-carrying reason, and calcium, which is vital for the coagulation cascade and cellular signaling.
Okay, so we have a patient whose connective tissue is overstretched and whose blood is potentially starved of the basic building blocks for tissue repair. How do we objectively know when their physiology has stabilized enough to safely bring them into the operating room?
Well, you rely on very rigid parameters. First, the patient's weight must be strictly stable for at least 3 months.
Not just trending down.
No, not fluctuating, not slowly trending down, completely stable. Furthermore, you must wait up to 18 months after their initial bariatric surgery before even considering a contouring procedure.
Why specifically 18 months, though? Like, what is happening at that physiological milestone?
It takes roughly that long for the body to reach true metabolic equilibrium. I mean, during the first year after a gastric bypass, the patient is in a massive catabolic state.
Oh, because they are literally eating their own reserves.
Exactly. They are in a negative nitrogen balance, breaking down their own tissue. If you perform major surgery during active weight loss, they literally do not have the protein reserves or the metabolic bandwidth to synthesize new collagen. They will fall apart.
That makes total sense. They need to be consuming at least 70 grams of protein per day just to fuel the tissue repair and abdominoplasty demands. Now let's talk about the physical state of the tissue itself. What is the absolute hard stop for BMI?
The ideal BMI for body contouring is less than 28, but the hard stop warning bell rings loudly at a BMI of 35.
Why is 35 the magic number?
Because operating on a patient with a BMI over 35 is directly associated with a catastrophic rise in severe wound healing problems.
Because adipose tissue is notoriously poorly vascularized, right?
Exactly right. Fat has a shockingly sparse capillary network compared to muscle or dermis. When you have extremely thick layers of subcutaneous fat in a patient with a BMI over 35, that tissue is already living on the brink of ischemia.
Just baseline ischemia.
Yeah, and when you add the trauma of surgical undermining and severing the perforators, that thick fat layer simply liquefies. It causes massive seromas, deep space infections, and total wound dehiscence.
Man, it sounds like we need a highly standardized way to assess and communicate the severity of these physical deformities before we ever pick up a scalpel.
You absolutely do. And the gold standard to cite for the exam is the Pittsburgh Weight Loss Deformity Scale.
Or Pittsburgh scale, got it.
Right. It systematically grades the severity of tissue redundancy and contour problems across different body regions from grade 0 to 3. It provides an objective language to justify your surgical plan. And you really need that justification because the complication profile here is completely different from a standard cosmetic patient.
Let's quantify that difference. For a standard healthy patient getting a cosmetic abdominoplasty, you might see a complication rate of, what, around 15%? What does that jump to for the massive weight loss patient?
It skyrockets to 50%.
Wait, 50%?
Yes. Half of your massive weight loss patients will experience a complication, whether it is delayed healing, a seroma, or worse.
Wow. That means your preoperative informed consent process has to be absolutely bulletproof.
It really does.
You have to aggressively manage expectations. For instance, explaining that stretch or stretch marks, they're permanent dermal stars. They will persist, and because we're pulling the remaining compromised skin taut, they might actually look wider or more pronounced postoperatively.
Yeah, that's a tough conversation. You also have to prepare them for the timeline. Swelling doesn't just vanish. It takes a minimum of 6 weeks to even start resolving because you have severed the major abdominal lymphatic channels.
Right.
The final contour won't truly settle for a full 6 months. And if their deformity requires staged procedures, say an abdominoplasty followed by a lower body lift, those major physiologic hits must be separated by at least 3 months to let the systemic inflammatory response calm down.
All right, so the patient is physiologically optimized, fully counseled, and we are finally ready for the OR. Let's start with the preoperative markings. We always mark in the standing position because gravity reveals the true extent of the overhanging tissue, right?
By standing, yes.
Now, patients naturally want to dictate scar placement to hide it under their preferred clothing, and they often ask for a high lateral French bikini pattern. But there is a hidden anatomical trap here if we chase that high riding incision line.
There is, and it sits right near the anterior superior iliac spine, the ASIS. When you extend your incisions high and laterally to hide them in that French bikini line, you expose the lateral femoral cutaneous nerve.
The LFCN.
Exactly. The LFCN emerges right around the ASIS. If you dissect blindly or take aggressive, deep fascial bites with your sutures in that area, you risk dividing or entrapping that nerve.
Which causes what?
The result is permanent numbness, or even worse, an agonizing, debilitating neuroma over the lateral thigh.
Leaving a patient with chronic nerve pain after an aesthetic contouring procedure is just an absolute disaster.
It's the worst-case scenario.
So assuming we stay safe and avoid the LFCN, walk us through the standard procedural mechanics of a classic abdominoplasty.
Sure. After you make your lower abdominal and periumbilical incisions, you begin your superior undermining at the subscarpus level. You take this dissection all the way up to the costal margins and the xiphoid, but critically, as you dissect, you purposefully leave a thin layer of areolar tissue undisturbed over the deep abdominal muscle fascia.
And the mechanism behind that is purely preventative, right? We are trying to preserve the fragile lymphatic channels resting on the deep fascia to drastically reduce the rate of postoperative seromas.
Precisely. You don't want a smooth, perfectly clean fascial plane there. Once the flap is elevated, you perform your rectus sheath plication.
Right.
You are suturing the anterior rectus fascia in the midline to repair the diastasis and tighten the abdominal wall like an internal corset.
You know, I think it is worth noting here that if you look closely at the literature, there is actually some conflicting evidence about the true multi-year longevity of that rectus plication holding its tension. But structurally, for the exam, it remains the absolute standard of care to perform and describe.
It definitely does. So then you pull the skin flap inferiorly, resect the excess, and begin your multi-layer closure. And this brings us right back to our foundation. You must specifically reapproximate scarpus fascia.
Because of the tension.
Right. By securely suturing this deep layer of the SFS, you bear the mechanical tension of the closure, protecting your delicate epidermal skin edges from ischemia.
Okay, that brings us to the umbilicus, which is easily one of the most mechanically confusing parts of the procedure.
It really is.
We are essentially isolating the belly button on a stalk, leaving it attached to the abdominal wall, pulling the giant upper abdominal skin flap down over it, and pulling the umbilicus out through a new hole. I always struggle visualizing how this isolated stalk of tissue survives. I mean, if we sever it from the surrounding skin, aren't we just leaving a piece of dead, devascularized tissue in the center of the abdomen? Where's the blood actually coming from?
Yeah, it seems counterintuitive, but it survives because the umbilical stalk is a highly collateralized vascular hub. It actually relies on 4 distinct sources of blood supply.
Okay, what are they?
Number 1, the subdermal plexus from the tiny bit of local tissue left at its base. Number 2, a direct perforating branch feeding it from below, coming off the deep inferior epigastric artery.
God.
Number 3, vascular contributions coming down from the liver via the ligamentum teres. And number 4, flow coming up from the bladder via the median umbilical ligament.
Wow, so it's getting hit from all sides.
Exactly. If you preserve a robust core of tissue around that stalk and don't aggressively thin it out, those 4 distinct pathways keep it perfectly perfused.
Okay, here is where the vascular physics get really fascinating for the exam. Let's talk about the Hugers zones paradox.
Yes.
If we map the abdominal blood supply, Huger zone 1 is the central epigastric region above the umbilicus,
Yeah.
fed by the deep superior and inferior epigastric vessels. Zone 2 is the lower abdominal triangle down to the pubis, fed by the superficial circumflex iliacs and external pudendals. And Zone 3 comprises the lateral flanks, supplied by the intercostal, subcostal, and lumbar perforators.
That is the map right there. Now apply it to the standard abdominoplasty we just described.
Right.
When you make your low transverse incision and undermine all the way up to the ribs, you are physically cutting through all the blood vessels in Zone 1 and Zone 2 from below.
So the central supply is gone.
Yes. The entire massive abdominal skin flap you just created is now surviving almost exclusively on the blood flowing in from the lateral edges, the Zone 3 vessels.
Right. So the flap lives on Zone 3, but here's the paradox. What if the surgeon decides to do a lipoabdominoplasty? Like, they want to aggressively suction the lateral flanks to snatch the waist.
Which patients love to ask for.
Exactly. But if I take a liposuction cannula into those flanks, I am essentially blindly driving a tunnel boring machine through a delicate grid of water pipes. I am indiscriminately shredding those vital lateral intercostal perforators. If I do a full traditional undermining and I lipo the flanks, haven't I just burned all my vascular bridges and guaranteed total flap necrosis?
Your mechanical deduction is exactly right. If you do both, the flap dies.
It's just simple math.
It is. That is why a lipoabdominoplasty requires a total alteration in surgical technique. Because your liposuction acts like a tunnel boring machine destroying the Zone 3 lateral supply, you absolutely cannot perform a wide traditional superior undermining.
Okay, so what do you do instead?
Instead, your surgical elevation must be strictly limited to the infraumbilical region and only a very narrow vertical midline strip above the umbilicus, just wide enough to allow you to plicate the rectus muscles and manage the umbilical stalk.
So by leaving the vast majority of the upper skin flap firmly attached to the deep fascia laterally, we preserve the massive zone epigastric perforators.
Exactly.
We completely flip the vascular survival strategy of the flap from the sides to the center.
Exactly. You respect the vascular physics, and the tissue survives.
That is a phenomenal explanation. Let's run through the biomechanics of the other major procedural variations real quick. First up, the mini abdominoplasty.
Sure. This is strictly for patients whose laxity is isolated to the lower abdomen. The defining mechanical feature is that your surgical undermining stops at the level of the umbilicus. You never dissect up to the costal margins, and the umbilicus remains entirely attached to the native abdominal skin.
Okay, next, the fleur-de-lis. Why isn't a standard horizontal cut enough for a massive weight loss patient?
Because a massive weight loss patient isn't just dealing with a vertical apron of skin. They are essentially a deflated cylinder. They have massive horizontal tissue excess as well.
Right, the skin folds in on itself from the sides.
Right. So the fleur-de-lis uses an inverted T-shaped excision. The vertical limb of that T allows you to physically pull the lateral flanks in circumferentially, severely tightening the waist. And structurally, because you are excising that tissue directly, it actually limits the amount of lateral undermining you need to do, which beautifully preserves the lateral blood supply.
What about the reverse abdominoplasty? I know we hide the scar up in the inframammary folds beneath the breasts for that one.
Right, so instead of a low suprapubic scar, you undermine from the top down and pull the excess upper abdominal tissue upwards. It is ideal for isolated epigastric laxity.
That makes sense.
But the most brilliant mechanical advantage here is that instead of just throwing that excess superior dermal fat flap in the surgical bin, you can de-epithelialize it, tunnel it upwards, and use it as a completely autologous breast augmentation.
Incredible use of local tissue. Okay, finally, take us back to that intense imagery from the very beginning of the deep dive, the paniculectomy.
Right, so this is a purely functional salvage operation, not an aesthetic one. It is indicated for patients with a massive overhanging apron of skin and fat, a pannus, that causes chronic intertrigo immobility and functional impairment.
It's purely about quality of life.
Exactly. The surgical mechanics are starkly different. You are essentially performing an amputation. There is no wide superior undermining. There is no rectus sheath plication. You simply resect the hanging mass.
And because of the sheer gravitational weight of that mass, you physically cannot retract it by hand.
No, you can't. The pannus is often so heavy that to even access the base of it to make your incisions, the tissue has to be pierced with heavy orthopedic hooks and suspended from the ceiling or hoisted by a specialized surgical crane.
Unbelievable.
Yeah. And because you are leaving behind a massive dead space in poorly vascularized fat, often in patients with severe metabolic comorbidities, the post-operative wound infection and dehiscence rates are exceptionally high.
It is a phenomenal visualization of the extremes of this specialty. To wrap up our deep dive today, I want to leave you with a final thought on the fascinating intersection between surgical anatomy and cultural trends.
This is a great topic.
Yeah. Notice how we didn't mention the high lateral tension abdominoplasty described by Lockwood in our variations rundown.
Yeah.
That technique relies heavily on a robust SFS repair, using heavy braided nylon to pull the tissue laterally rather than straight down. It flattens the abdomen, actively lifts the anterior thighs, and crucially leaves a scar that rides very high in the hips.
Which used to be exactly what everyone wanted.
Exactly. Why was this popularized in the 1980s and early 90s? It was completely driven by the fashion trend of high-leg Baywatch-style swimwear. Women needed surgical stars that hid seamlessly under those steep, high-cut waistlines.
But as fashion evolved, that technique became a huge problem. Today, modern fashion demands low-rise clothing, hip huggers, and, tiny string bikinis.
Right.
Surgeons were forced to abandon that high lateral vector because it exposed the scar. We had to pivot back to the low, straight, transverse scar we prioritize today just to keep it hidden below modern waistlines.
Exactly. The underlying anatomy of the SFS and the vascular zones absolutely never changes, but what society demands we do with that anatomy shifts every single decade. It really challenges you to consider, as aesthetic trends continue to evolve, perhaps toward hypermuscular core definition or entirely new, unpredictable clothing profiles, how will future fashion force the next major evolution in our flap design and vector mechanics?
It is a brilliant reminder that surgical technique doesn't exist in a vacuum. It is always adapting to the culture around it.
Spot on. If you found today's physiological breakdown helpful for your FRCS prep, please press follow on the show right now so you don't miss our upcoming revision deep dives, and leave us a rating if you learned something new today. And one final reminder, head to medsynclimited.com and get the FRCS Plastic Surgery Anki Deck with over 6,000 questions arranged by topic to help recall key facts, based on the textbook keynotes in plastic surgery. We would also love to hear your thoughts or any clinical deductions you've made. Leave a comment or a question about today's deep dive in the show notes. Keep grinding, keep studying the mechanisms, and we will catch you on the next one.